The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
Well, good morning everyone. As I was introduced, my name is Richard McKay. I'm an Associate Nurse Unit Manager from Austin Health in Melbourne in the Intensive Care Department. Obviously you can see the title behind me there, What Nurses Do at a Met Call. And I guess the word that I'd really like to highlight there to start with is that word do. What nurses do at a Met Call. And so can I suggest that most, if not all of you, have been to a routine Met Call at some stage? Can I get you to think back to perhaps one of those Met Calls, whether it was a short time ago or perhaps a longer time ago for some of us? Think back to the facility that you're at. The chimes go off, you're alerted to a patient in distress, you report to the ward environment. On arrival there, you see that there's some nurses, maybe a doctor or two, obviously the patient that's there that's distressed. Can you think about what you actually did? You obviously introduced yourself, but then what did you go ahead and do? Well, hopefully you didn't prime a line and get some cannulas going, look at their central access and put them on VA ECMO. If they're needing that kind of thing, then perhaps a Met Call was not really substantial enough for them. Again, I'm hoping you didn't get one of these going and put them on autopilot, something like that, and send them off to CCU for further diagnostics. And again, too, hopefully one of these didn't rear its ugly head as you tried to prime it and get it through all of its own checks, perhaps a little bit later on. And maybe some of those things were later on. But what we'd like to highlight today is what nurses do at Met Calls, those routine Met Calls. And why we do that? Well, there's minimal information that we could find about the roles that the Met nurse actually did at those calls, their interventions. We couldn't find a study as far as those specific roles were concerned. And so we thought this would be very important for a guide for education going forward, not necessarily those ALS type things, but perhaps more at a Met level. So we conducted an 8-week prospective audit. This was undertaken by the nursing members of the Met during routine Met Calls. So how do we go about that? We had a standardised case report form for each of these Met Calls. We looked at the hospital switch as well as an ICU shift report that's done for the documentation, because there were going to be some that were missing, unfortunately. So we identified over 400 Met Calls during this period of 8 weeks. You can see there that 374 were entered electronically via the Met registrar or fellow in attendance, and 309 were done prospectively via these forms via the Met nurse. So some interesting information. There's a few slides based on that. The median age that we found was 73 years of age. 25% of the calls occurred in those patients that were older than 83 years. Of the 400 Met Calls during that 8-week period, 29 were transferred to ICU for ICUHDU level care. Of those 29, unfortunately 10 had their forms missing, perhaps due to the instance that was going on, what the patient needed. You know, they're coming down to intensive care, so perhaps the paperwork was a little bit missing there. And of those forms, there were 81 of the remaining 371 that were not completed, that weren't admitted to ICU. So what did these patients come into hospital for? I guess there's no surprises there. Their hospital admissions with higher numbers of gastrointestinal conditions, orthopaedic, oncological, common kind of reasons why patients are coming in through ED and in through other avenues. And there's another criteria down there as well. Again, the top three that we see very frequently at our facility, triggers for Met Calls: hypotension, tachycardia, hypoxemia. These are ones that we can rattle off without getting any kind of formal numbers on, but the formal numbers are there nonetheless, you know, 1 in 5 type thing. We've also got the worried criteria down the bottom. Our facility has a worried criteria where if patients aren't necessarily meeting any other numbers or any other triggers, the nurse or the attendant there can still call the Met if they are concerned, if they are that worried. Other details that we found, just on 90% of patients remained on the ward post the Met Call, which is the ideal place for them. Unfortunately, 2 passed away with existing NFR orders either during the Met or post the Met during the night. And The remaining were transferred to another unit, aside from those that stayed or those that came to intensive care. Just on a quarter had limitations of medical treatment orders in place prior to the Met call. Just under a third had them put in place post the Met call. The median time spent at a Met call via those Met nurses was 30 minutes. And quite alarmingly to me, perhaps not to others, 10% of the calls, the nurse spent at least 85 minutes at that Met call. Don't know what was going on at that Met call, but my word, it was a long time. So the demographic, again, this is not anything that's terribly surprising. We can see that these patients had various backgrounds as far as medical or surgical complications, their units. The time of day that these Mets were called, again, not surprising to see that most of them were during business hours and then leaking through into the night. So as you can see there, the physiological triggers and technical skills completed. So this was a table that was completed by the nurse at the Met call. And you can see there the various systems and the various tasks that they had to complete. But highlighted in red are the 3 most completed tasks or interventions by these nurses. Now, as we alluded to earlier, priming an ECMO circuit, putting someone on a balloon pump, these were not what we found. As you can see there under breathing, clinically examining the chest, circulation, clinically examining the circulation, and under nervous system, assessing GCS. These were the 3 most common interventions that were done. Now, certainly these aren't necessarily things that we would associate critical care intervention with. An assessment of breathing, of circulation, and of their Glasgow coma. So other tasks that were performed there, a third reviewed an investigation, 18% contributed to the acquisition of a history in these patients. The Met nurses documented that they felt directly contributing to the patient management plan in about 40%. Obviously education is a key one there, so education of a clinical assessment and regarding equipment, again, 16 and 14% respectively. They completed handwritten notes, electronic records, applied monitoring in a fifth of patients, and supervisor transport in 12%, whether that be to intensive care or another department for a scan or for the patient movement. We also looked at who the reassurance and or explanation was aimed to on the ward by the nurse. And it's no surprise that just under 80% was directed to the bedside nurse. Obviously the family and or patient members were receiving a lot of explanation and reassurance as well, just shy of 40%. We also had a mark of self-reported confidence and competence. It's a little bit of a tongue twister, but we wanted the nurses to document how they were feeling at these routine Met calls. Much different from that more advanced Met call, that respond blue call. And not surprisingly, most of our colleagues said that they were confident and competent. So a summary of what we found, we were able to capture data on more than 75% of calls, 309 out of the 400. We felt that the patients that we captured during that time were a reasonable representation of all those that would normally receive Met calls over that 8-week period. There was certainly a high correlation between the primary criteria leading to the activation and thus the subsequent tasks that were performed by the Met nurses, which is obvious. You call a Met call for problem A, there's probably going to be something that goes along with problem A as far as their assessment or their management or their treatment. Most of the nurses felt that they were confident and competent, which is certainly not a surprise, and there were 12% of patients were transferred. So again, these non-technical skills were performed far more commonly than those that were deemed technical. Critical care interventions were not recorded in a high proportion of these calls. It wasn't those advanced technical skills that our nurses were recording that they were instigating and using to manage their patients. The information that we've gathered here would hopefully thus be used for training and planning for the future, knowing that that's what these nurses are mostly doing. And certainly communication and education were very commonly performed Obviously, communication is one of those key facets that our nurses were using on the wards, whether that be with the patient, those in the team, transferring, everything that goes along with it. And certainly this was the first study that we had found of this kind. Of course, there are limitations to every study. This was indeed a single centre study that was performed. Unfortunately, we missed data of approximately a quarter of those calls overall. Of the missing data, a third of them were patients that were admitted to ICU, and thus there were reasons for that. We can't comment on the appropriateness of what the nurses actually did. Yes, they documented what the physiological trigger was and what they thus did as a response, but whether that was appropriate or not, we weren't there, so that's not for us to comment on. There was certainly a high level of self-reported confidence and competence, but that doesn't, again, necessarily correlate to an objective measure of what that means. We have a very mature met nurse pool that we're able to call on, and so that may reflect the way that they approach things, as well as the standardised approach that we have to training at our facility. So where are we at from a relevance point of view? Well, hopefully this does provide a relevant stepping stone for training and education of our met nurses versus other facilities. Certainly the data is relevant as far as at critical care level and postgraduate programs and what these nurses are being taught, perhaps moving into the future when they are looking at becoming outreach nurses. Certainly communication was implemented at the majority of calls, and we would suggest that even when it wasn't documented, that it was actually being used to whatever level, to whatever degree. Perhaps in smaller groups we could look at the assessment of clinical skills, maybe via bedside teaching, and those critical care interventions, those ones that were infrequently performed, those technical level skills, perhaps that would be good in team training. So where to from here? Certainly that's a little bit of information, but where do we go from here? Perhaps that's something that our colleagues can discuss in their points. Thank you very much for your time.